a pleasure to be here, and I'm very happy to speak with you. Thank you, Chris Plow and John Bartlett, for the invitation. I'm very happy to be here. In thinking about preparing this talk, I have you in my mind. So I guess, my goal is to tell you obviously a lot about this disease, and then, but the main thing I want you to take out of this is the experience of how I sort of view my research career around it, and I would like to hopefully inspire you to do similar thing and give you some wisdom that I've collected over the past decade doing this. So I guess at the end of this talk, I will then talk about how you could do similar thing at your stage of training. And that's the goal of the talk. So I usually start out with giving you an introduction of where I've been, my training, and the people that make a significant contribution to my career as a mentor. And that's really one of the key area that I want you to take home as well. So my interest in public health and infectious disease had very, very deep root. Started out in college when I read the book, The Virus Hunters of the CDC. And that just led me to the CDC after college. I wanted to know what kind of work CDC does, so I enrolled in the Emerging Infectious Disease Fellowship. This is not the EIS program, it's an EID program for bachelor and master level. I don't know if they still have that program, but they pair you up with an epidemic intelligence service officers, and so you get to go to investigate disease epidemic in the country, but also worldwide. And that was really an interesting experience, and that really inspired me to go to medical school so that I can do EIS. I went to medical school in Arizona, and I did my internal medicine residency at Tufts in Boston, and I worked a lot with Sherry Gorbart, who is now retired from being chief editor of CID for many, many years. He's the person that really allowed me to go to Vietnam when I was a resident, and that's where I actually learned a lot about global health. These sort of experience where you are, your level, really have shaped my interest in what I do over the last decade. I did my infectious disease training at Yale and learned from mycosis and Gerald Phelan a lot about HIV. When I finished ID fellowship, I was given some option, and really attractive option. One of them is to work with Mike on clinical trial on HIV. The other option is to start a ID transplant program at Yale, and that was really a good opportunity, but I turned them down and took a less known role. So I took a Fogarty Fellowship, International Clinical Research Fellowship, and went to Vietnam. And that really was the experience that I had doing residency and doing Yale. I wanted to do some international global health research, and actually took that investment to go overseas and be a fellow, research fellow all over again after ID training. So I went to Vietnam and spent the last 8 to 9 years at the Oxford University Clinical Research Unit in Ho Chi Minh City. I did a PhD in epidemiology during that time, and initially didn't mean to study talaromycosis, and I'll tell you that story as well. Meant to study HIV drug resistance, but as I went to the ward and see patients with talaromycosis, this fungal disease that I've never seen, but studied about it, doing my ID board study, actually I've never saw a case. I decided to really switch and study this, and how I started the career. And just this year I moved to Duke to further my research, and after 10 years of doing clinical research overseas, I realized that there's only so much I can continue. Running another trial, certainly, but in order to run trial, you really need a lot more preparations in terms of basic science, animal work, in order to identify the right compound to test. And that's the reason that I came to do. Now working with John Perfect, Joe Hyman, and Andy Osborne to develop animal model to test therapeutics and do continue to work on this pathogen, Talaromyces. So that's my introductions of my background. In terms of the disease, I wanted to step back and take Michael's point that it's a regional disease. It's a small problem. And I would argue is nothing is really a small problem when you look at the patient perspective. But South and Southeast Asia in this circle is really 4 hours flight, and it has more than half of the world population. So highly density, this is one of the area, the hot spot for emerging and re-emerging infectious diseases, and this is a really fascinating place to study tropical medicines and global health. So I really encourage you to look in Asia as well. If you're looking for places to go and make a difference, there's still a lot to do in this part of the world. So Oxford University Clinical Research Unit is an organization funded by the Wellcome Trust in the UK, and they've been in Vietnam for nearly 3 decades. And based at the Hospital for Tropical Diseases, which is more than 100 years old. Initially started out as a TB hospital for very neglected diseases, and now it's a center for primary, secondary, and tertiary referral center for all tropical infection in southern Vietnam, with a catchment population of 40 million people. So we do see a lot of different tropical diseases, from malaria, dengue, enteric infection, emerging infection, influenza, H5N1, SARS, are some of the diseases that we saw and took care of here at this hospital. We studied tuberculosis, central nervous system infection, HIV, zoonosis, and we have a clinical trial unit and biostatistics and modeling group that support all the things that we do. There are 4 different units in Southeast Asia, so mainly in Ho Chi Minh City, but we have sister units in Hanoi, Kathmandu, and Jakarta. And we're working very closely with the Wellcome Trust major overseas program in Thailand as well. So here we are. The Oxford unit is located within the hospital. We are based in the hospital laboratory, which is only a few steps away from the hospital ward. So we have very close relationship with the hospital, and it's a fascinating place to do clinical research. And this is one of the pictures of a typical afternoon in Ho Chi Minh City. You can see how crowded it is. How many people here have traveled to Vietnam? All right. It's a fascinating country to visit, nothing like it. All right, so this graph shows the mortality at our hospital over the last 14 years. And as you can see here, mortality began to decrease in the 90s, but then it started to increase, and that mortality increase was due to HIV mortality in blue. And when we look at causes of death, the major cause of death in HIV patients is tuberculosis. Similar in Africa, 40% of patients die of tuberculosis, followed by invasive mycoses, cryptococcosis, talaromycosis, and pneumocystosis are the major player here. So talaromycosis used to be called penicilliosis, for those of you referring to the name. So Penicillium marneffei recently changed name to Talaromyces marneffei, and so the disease is now called talaromycosis. It's this is just to show you that our research are based on clinical trials. So we are mainly running clinical research based on with outcome looking at mortality difference. to guide treatments. So that's basically our track record of delivering clinical trial in very high impact journal. We're basically the one who identified dexamethasone with mortality benefit in tuberculosis, meningitis, dexamethasone in treatment of bacterial meningitis, treatment of malaria, and combination therapy for cryptococcal meningitis. Recently, last year, we published a paper that showed adjunctive steroids harmful for patients with cryptococcal meningitis, and this is our trial that showed amphotericin B had mortality benefit compared to itraconazole in talaromycosis. So our treatments really inform treatment guidelines, trial inform treatment guidelines, and this form the basis of our work. Go back to talaromycosis. So it's one of the 7 major endemic mycoses of medical importance in the world. So you may have heard about histoplasmosis, coccidiomycosis, blastomycosis in North America. And in South America, we have paracocci, sporotrichosis in North and South America. In Africa, there's histoplasmosis, a different strain from the histoplasmosis in America. And in South Africa, we have mycosis. In Asia, we have talaromycosis. So these are the 7 major endemic mycoses of medical importance in the world. And they share similar characteristics in a way that they cause high morbidity, mortality, primarily infect immunocompromised population, HIV predominantly, but also can affect immunocompetent people. And they are dimorphic, so they are more in the environment. They adapt to the warm-blooded host and switch to a yeast, so they are dimorphic fungi. So Talaromyces is endemic in all countries in Southeast Asia and highly endemic in southern China, north and south Vietnam, northern part of Thailand, also in Myanmar, but we don't have a lot of data for Myanmar because of the lack of microbiology diagnosis. But I know that there's a lot of disease in Myanmar, Thailand, Vietnam, and southern China. But it's also involved in other Southeast Asian countries, somehow very highly endemic here in these countries. And I'll tell you why later on. So the disease is discovered in bamboo rats. So bamboo rats are animals that roam the highland area in Southeast Asia. They live deep down in the ground, under the ground. They're burrowing animal, and they come out at night and feed on bamboo shoots and roots. So we would discover when these bamboo rats was used as experimental model to study Susugamushi fever. And researcher from the Pasteur Institute in Dalat, Vietnam, was studying this, and they identified this fungus in the spleen and liver of these bamboo rats, and they identified for the first time. What is different about it is that it's a penicillium strain, but out of more than 300 strains, it's very different in a way that it's dimorphic that I mentioned before. So it's a mole in the environment, and very much like an Aspergillus mole, but in warm-blooded hosts is switched to a yeast. So that's the single characteristic that differentiates this from the rest of 300 penicillium mole out there. And so they discovered that in 1956, and the disease was very rare. So basically, identifying a few patients. The first few patients was actually American. In 1973, someone who had histories of travel in Southeast Asia had Hodgkin disease and developed basically Hodgkin disease. The treatment back then was to remove the spleen, and they identified Talaromyces in this patient. And then in another patient also in America in 1984 in South Carolina, and someone with recurrent hemoptysis. So it's very rare. And then in the 80s, they begin to report cases in Bangkok and from southern China. So it's very rare until HIV epidemic arrived in Southeast Asia. This emerged rapidly to become one of the most common opportunistic infections that we see in Southeast Asia. So this graph shows the temporal emergence of talaromycosis and HIV in northern Thailand. And now it's the third most common opportunistic infection after tuberculosis and cryptococcal meningitis in the area, in highly endemic area. The case fatality rate is very high. Without treatment, everybody died. And with antifungal therapy, mortality is 30%. So very, very significant morbidity and mortality. So when I came to Vietnam and saw the first patient in 2008, I began to change my direction. I wanted to understand about the epidemiology and try to make a difference in this disease, because pretty much every 1 out of 5 patients that I saw has the condition, and not much has been done. This is sort of an opportunity that arrived at my door, and I wanted to study this. And over the past 8 years, I built a research platform to study this, and started out with understanding the epidemiology of the infection, and then tried to develop novel diagnostic, because diagnosis is based on culture, and culture take a long time and it's low yield. I also study antifungal susceptibility, pharmacodynamic, pharmacokinetics, and in conjunction with clinical trial to really understand all these aspects and improve treatment for patients. And now moving to Duke, I hope to develop more translational capacity to understand pathogenesis. And I mentioned before, animal model to study compound to test it in clinical trials. So this is sort of my platform, and how I build this to build a career around this fungal pathogen is what I'm going to talk about next. So this picture just to show you very basic thing that I started, and it's not without a lot of sweat. So when I came, and there's really one case series of 12 patients were described in Vietnam. And so I wanted to understand the epidemic code. And the only way to do that fast is to do a retrospective study. And retrospective charge review, and this is Vietnam medical record in its hospital. It's not alphabetical. Yeah. And if you're lucky, it's basically these things by year and by month. Yeah. So you basically go through first with a microbiology record, you know who had culture positive confirmed disease, and you go through and you have to eliminate duplicates, because if you come in the hospital 10 times in 1 year, you get 10 different medical records, 10 different charts, and so you have to kind of tally them up and make sure you don't have duplicate. And after you do that, you go through this little warehouse and go through all these and get charts. So out of 800 culture confirmed disease, and that is an underdiagnosed, right? Because obviously culture is not the best way to diagnose. Out of 800, we got 500 charts. So we did very well. 6 months of sweat and work with Dr. Lam. So we basically dropped this epidemic code from the very first case in 1996, when the first HIV case occurred in a hospital, and basically dropped the epidemic code. And as you see that it has very nice temporal relationship with HIV admission at our hospital. And at one point we saw about 150 cases a year. And now we still see about 100 cases a year. It hasn't gone down, because despite HIV antiretroviral therapy, there's still a lot of patients who come late for treatment, and patient with treatment failure. So the disease is not going away despite universal antiretroviral therapy access. And we did a basic clinical epidemiology description of the disease. So this is, at the time, the largest case series to date of more than 500 patients. We described the disease epidemiology. Basically, it's a subacute illness from 1 to 4 weeks. Patient present with very constitutional symptoms that you cannot differentiate from tuberculosis, disseminated fungal infections, or salmonella and other things. The very specific feature is skin lesions. So up to 70% of patients will have skin lesions and develop on their face. Skin lesions are very typical. They look like molluscum, so they're nodule and has a central implications. Mostly start on the face. But skin lesions are very late manifestation of the disease. By the time the patient has skin lesion, it's very late, and they've already have formed and disseminated disease in the blood and disseminate to the skin. So by the time they come with skin lesions, they've already been in the hospital multiple times for fever of unknown origin. So there's definitely room for early diagnosis. There's multi-system involvement, but mostly reticular endothelial system, so liver, spleen, lymph node, bone marrow involvement, very much like disseminated TB. CD4 count is 7, so very profoundly immunosuppressed patient with HIV. Treatment, 60% of patients receive itraconazole, which is an oral drug that's readily available, generic, cheap, and 30% of patients receive M4B, and this is really very random based on the ability to pay, because everything is out of pocket in Vietnam. It's less sociable than America, less socialist than America. So basically, not many people can afford amphotericin B, but also not a lot of doctors willing to treat with M4B because it's a toxic drug. And so that's the state of the art. And not much has been done. There's never been a clinical trial evaluating treatment of this severe lethal infection. Hospital mortality was 28%. So there's a lot to be done. We described the first series of central nervous system.
What do people tend to die from, those who don't survive?
They die mostly from disseminated fungal infection. So they would be very wasted by the end, and most people die from respiratory failure, multi-system disease. So we described the first case series of central nervous system infection. It's very rare, but 1% of patients had central nervous system infection. We described multiple co-infection and dilemma associated with multiple co-infection. We also the first people to describe paradoxical iris in this disease. Prior to us doing this study, there's only cases of unmasking iris. I know these are very medical terms for you, but we basically describe a phenomenon where you treat these patients and you start them on antiretroviral therapy. Within about 3 to 4 months, when the immune system sort of wake up, they develop a paradoxical worsening of disease. And so we'll describe this case series of these patients. Luckily, none of these patients die. You can treat these paradoxical iris cases, but they're very high morbidity in these patients. And we don't know why these patients are prone to these paradoxical phenomena. So recently, I've also went to China because the disease is very prevalent in southern China. And so beyond Vietnam, I wanted to go to southern China and Myanmar and other places with high burden and understand the epidemiology of this. So in China, the disease is somehow only prevalent in southern China. And this is an epidemic code in one of the major hospitals in Guangzhou. And this is my collaborator, Dr. Lee. We just basically draw up this map. And as you can see, in southern China, HIV is rising. And it's basically surprised me. Look at the number of AIDS going up rapidly in 2017. The number of cases of talaromycosis now, 250 cases a year in this hospital. And basically, this has never been reported. So there's so much work to be done. We need to estimate global burden of this infection. Again, when you're working with a neglected disease, it will remain neglected unless you spend time and estimate the burden of disease and tell people the impact of this disease on patients. So this is what we are going to do. We need to have an estimate of global burden. And I'm working with a postdoc in Guangxi in China because a lot of disease are reported in China in Chinese literature. And the only way to get to it is to work in with Chinese investigators. And so we identified more than 20,000 case reports in 33 countries so far, and 99.5% are from Asia, and the highest numbers come from China, Thailand, and Vietnam. And as mentioned before, there's a lot of disease in northeastern part of Burma that has not been reported. 20% are in non-HIV infected patients. A lot of these patients had some underlying immunodeficiency condition. 6% occurs in children, and so we need to establish incidence as well based on incidence of HIV/AIDS in the region. So a lot of work needs to be done. I'm going to go quickly on the understanding not just clinical epidemiology, but environmental epidemiology, right? This is very interesting infection. It is not a human-to-human transmission. It is from the environment to human. So in other words, saponosis infection. And where is it in the environment? Why does it have the geographic geographic limitations, and what is it in the environment that put the patient at risk? So we started describing the seasonality of this infection. This is a study from Thailand showing that it's very seasonal. So from May to October in northern Thailand, they could see an increase in number of cases. I think this is talaromycosis here, sorry, yes. So this is talaromycosis incident. These are rainy season. This is actually number of rainfall, the volume of rainfall. And this is number of cryptococcal meningitis. So cryptococcal meningitis, similar host in the same region, is not seasonal. But talaromycosis is definitely seasonal. And we wanted to see if we see the same thing in southern Vietnam. This is our data over 6 years period, and we didn't aggregate the data. We actually looked at incident by year. And as you can see by year, from June to about November, the rainy season in southern Vietnam, you see this beautiful sinusoidal shape. So we see about 30% increase in incidence every year. The question is, what is it about seasonality? Is it temperature, humidity, rainfall, wind speed? What is it about the weather factor that predicts this seasonality? So we did this in collaboration with a modeling group from UCLA, looking at weather factors, and we identified humidity is the independent predictors of incident and not rainfall, actually humidity. And the higher humidity, the higher odds of developing disease. So clearly this shows you something in the environment. So humidity facilitates an increase in environmental reservoir that increase exposure to patients. Going back to the bamboo rat now, what is it about these, and what does the bamboo rat has to do with the disease? Bamboo rat, like I mentioned, there are 4 species, and all of them carry Talaromyces asymptomatically. So they're well, in other words, they're well, and these studies in the region have shown, very high prevalence, up to 94%, so 10 to 94% in multiple survey in this area. These rats have Talaromyces in the lung, liver, and spleen, and they are well with it. So they clearly serve as a zoonotic reservoir of some sort. The question is whether there's a human, animal-to-human transmission. What we found is obviously where the bamboo rats are in the region, that's where the human cases are. And when people look at molecular epidemiology data, molecular typing of the strain from the bamboo rat to humans are nearly identical. So the question is whether there's an infection from animal to human sort of transmission risk. So the Thailand group did a case control study 2 decades ago now, in 80 cases and 160 control in Chiang Mai, Thailand. So Chiang Mai, Thailand Have you been in Chiang Mai? How many people have been in Chiang Mai, Thailand? Not many people have been to Asia. All right. So Thailand, Chiang Mai is a beautiful area and in mountainous region, sort of semi-rural area. And 90% of cases of talaromycosis in Thailand is in Chiang Mai. So again, the questions about the bamboo rat reservoir and the mountainous regions come to my mind when I approach the literature here. And when they did this case control study, they found that exposure or consumption to bamboo rat was not a risk factor. And 60% of patients in this case control study had exposure to bamboo rat, but that was not a risk factor. But exposure to plants and farm animals is a risk factor with an odds of nearly 2. So the question is whether it's in the soil. Obviously, like any other endemic mycosis that we know, soil is the reservoir. However, environmental reservoir remain a mystery to this day. Many efforts look into soil survey have not found the pathogen in the soil. So first, they have not found marneffei in the soil, in the air surrounding patient home, or actually in in the patient home or in the air or the soil. And the pathogen does not survive well in natural soil. In their laboratory experiment, they don't survive very well in natural soil. They don't compete very well with other soil pathogens, and they die very quickly after 3 to 4 days. So it cannot be a reservoir if it doesn't survive. And in multiple studies, they really have not identified a pathogen in the soil. But 2 recent studies have identified the pathogen in the soil in bamboo rat burrow. So it has to be associated with bamboo rat. So again, it brings back the question of bamboo rat. So I did this case control studies several years ago. Haven't published yet, just been so busy, but this is a very interesting case control study in Vietnam. So in Vietnam, 2/3 of the country is highland, right? So we've got mountainous region from north and south, very different geography than Chiang Mai. And I would argue this is a perfect place to do this case control study. So we recruit patients from Ho Chi Minh City and Hanoi in very urban setting. And we want to know, we evaluate very similar risk factors and risk factors, both host and environmental factors. And long story short, we found exactly the same thing. Our study is massive for case control study for this disease. We did this prospectively in 200 cases and 400 control, all have HIV/AIDS. And we found exactly the same thing, that exposure to plants and farm animals put the patient at risk. Again, point back to an environmental reservoir. I think the most interesting data come from our mapping data. When we map cases and control, we found that cases are more likely coming from the highland area. So when we did pairwise comparison of cases of control from different regions in southern Vietnam, we didn't have enough patients in northern Vietnam to do the analysis. Most patients were recruited from southern Vietnam. We found that case over control ratio is up to 2.5 times higher in the highland region compared to the Mekong Delta or Ho Chi Minh City to the lowland. And when we go back to ask patients who are living in the lowland Mekong Delta and Ho Chi Minh City if they ever traveled to the highland region, as short as a few days trip in their entire life. And we did this blindly. And we found that people who ever traveled to this region, as short as a few days, had a higher odds, 3 times the odds of having the disease compared to those who have never traveled. So this is the first epidemiological evidence that there are geographical risk factors within the endemic region. And finally explain the highly endemic area clusters around the highland regions in Southeast Asia. And again, bring the bamboo rat back to the picture. This map shows you the distribution of bamboo rats in Vietnam. So again, in the highland area. And so this is our theory that the pathogen has a reservoir in the environment, in the highland, in the soil, but it's required particular type of soil, and it needs animal, particularly bamboo rat. The bamboo rat burrow in the soil and has a very intimate relationship with the soil. And this pathogen take advantage of warm-blooded host to infect the host, to amplify more of itself, and use the bamboo rat as a vehicle to expand its geography and biomass, essentially. Without the bamboo rat, they don't compete very well, and they need help, and they need food. So and humans get infected because they live in the proximity in these regions or travel to these regions. So now that really, this data is important in terms of disease control, in terms of the advice that we give to patients who are immunosuppressed who travel to these endemic areas. And appropriate, we can tell them appropriately, in certain area, not every place in Southeast Asia, but probably mountainous area is a place where they should be careful and perhaps take primary prophylaxis. So I'm going to move now to our work in diagnosis and treatment. In terms of limitation in diagnosis, I mentioned before, the diagnosis is based on microscopy, so we need to have a lesion for you to put a needle in and get a biopsy to see the pathogen. This is very sensitive and a very quick method, but like I mentioned, patients come in multiple times before they get to a stage where they have skin lesions, so you would miss the diagnosis, and a lot of patients already die before the diagnosis is made. Culture take up to 14 days, so compared to other endemic mycosis, it's relatively fast actually. Histoplasmosis take 4 to 6 weeks, so this is relatively fast and grow in the blood in 70% of the time. But by the time the patient is blood culture positive, they probably very sick or die and do poorly. So very key to make early diagnosis. We have developed several new diagnostic assays, and we started with this very simple assay, and basically it's a quantitative culture assay. We take blood directly from patients and serodilute them and basically put very tiny drop into the plate and put them in the incubator, and we can count the colony forming unit. And this was simple, it's labor intensive, simple, but you can then map out the fungal clearance in the blood of patients. And this turned out to be, as I mentioned later, as I will mention later, a single most important prognostic indicators of disease outcome. In terms of molecular assay, people have worked on PCR, and PCR very specific. The problem with PCR is sensitivity for fungal infection. First, you have very small number of DNA in the blood from the fungus. So, and also the fungus have very thick cell wall, very difficult to break the cell wall to get to the DNA. And so we've tried very hard, and this is our study here, 70% sensitivity. So it's not better than blood culture, but it's quick. You can get PCR if it's positive, it's highly specific, and you can put the patient on therapy quickly. So PCR has a role for rapid diagnosis. It's not that sensitive. I think the better way to go is to do antigen tests for fungal diagnostic. So now, we've gone a long way to most recently having monoclonal antibody developed based on very immunogenic protein. So this is a group in Hong Kong who developed a monoclonal-based antigen detection ELISA. And they've tested in a small number of patients, only 20 patients, and sensitivity is 75%. But what I was impressed about is the specificity is 99.4 in patients with other opportunistic infection and in healthy subjects. So very high specificity, which is very rare for an immunological diagnostic test. And so I took this assay, actually they took this assay to screen for antigenemia in a large cohort of patients, more than 8,000 patients in southern China. And they identified antigenemia prevalent of 9.4%. And as they stratify a patient by CD4 count, as you see, as CD4 count decrease, antigenemia prevalent is 28%. So it's suggesting that antigenemia in HIV patients with profound immunosuppression is clinically significant, and that maybe we can use this assay to make early diagnosis. So I was very excited when I saw these kind of work come out of Hong Kong group. We took this assay to validate it in our lab, and we basically tested in our, this is archive sample in 370 culture-confirmed patients in the plasma, and in non-talaromycosis control, 500 patients with a range of different infections, but not talaromycosis. We exclude HIV in this control because we cannot exclude talaromycosis from HIV patients. And we really, this is how it performed very, very well, actually. And at the cutoff of 0.5, we identify a sensitivity of 86% and specificity of 98%, with a diagnostic AUC of 96%. So a diagnostic AUC is an area under the curve. It tells you how well, what's the probability of you differentiating someone with the disease and without disease. 96% of the time. That's pretty good. But this is a retrospective validation study. We need to understand how this test performs in patients who come into you with a differential diagnosis of this infection and see how well it predicts disease, having disease now, but also disease development in the future. So this is an area of active research in the area that I'm writing a grant, an NIH R1 about. But what is very exciting as well is we did this, there's a cohort of cryptococcal antigen cohort in Vietnam. This is a CDC-run cohort in 22 clinics in Vietnam. This is an implementations research where the CDC just wanted to do the cryptococcal antigen test and treat patients. So I basically took advantage of this cohort of more than 1,000 patients and did TM antigen screening. And what we found is really interesting. So what we found is that antigenemia for Talaromyces is present in overall 4.2% of HIV patients with CD4 count of less than 100. So these patients have no symptom. Starting antiretroviral therapy, no symptom, okay? And they have 4.2% of antigenemia in their blood. And we have higher prevalence in northern Vietnam than southern Vietnam, 6.7 versus 2.1%. But notice that our site in southern Vietnam is pretty much in the Mekong Delta and Ho Chi Minh City, which I've already told you from the case control study, the prevalence in the lowland is low. Whereas in northern Vietnam, a lot of these clinics are in the highland area. So I think it has to do with highland area, not really north and south phenomenon. But when we look at the people who are antigen positive, their levels are very high, very similar to culture positive disease level. And when we looked at impact on mortality, 12-month mortality, as you can see, that this is the first plot of the cohort here. People who are antigen positive are at 2 times at the hazard of death compared to those who are antigen negative. And this is independent from those who are cryptoantigen positive or low CD4 count and independent of age. So this is an independent predictor of 12-month mortality. And this is a Kaplan-Meier curve showing you mortality different in antigen positive versus antigen negative. So having an antigen in their blood basically predicts 12-month mortality independent of the major player of predictors of mortality here. This is not a cause and effect relationship we need to really work out. We need to do this study again prospectively to really understand whether antigenemia patient will develop disease, how does that happen. But this basically shows you that it impacts mortality and argue for early screening and preemptive therapy to prevent disease development. So this is our strategy. This is our future strategy, is to screen for disease at the preclinical stage and put them on preemptive antifungal therapy to prevent disease from development. This type of strategy really will make a huge difference in disease management. Right now, we're waiting for the patient to come in with a culture-confirmed disease to treat them, and they have 30% mortality on therapy. If you do this and screen all HIV patients with low CD4 count and preemptively treat them, this is much better than treat them late, but also much better than primary prophylactic, treating everybody with low CD4 count. This is a very, very feasible, practical strategy that will make a significant difference in morbidity and mortality. I run out of time. I want to give you time for questions, so I'm going to skip all these things.
No problem.
Sorry about that. So this is a trial that I mentioned before. We did this trial because there was no data in what to treat these patients with, and we got funding from the UK government to do this randomized trial in 5 different hospitals in Vietnam. And very interesting, we found, in previous studies, retrospective studies, there's no difference in mortality or clinical outcome in patients treated with itraconazole or amphotericin. But that's because the follow-up was very short. In this study, we follow patients for 6 months, and as you see, the Kaplan-Meier curve begin to split after about 2 months here, with excess mortality seen in patients treated with itraconazole arm. We don't see this effect until 2 months out, and a lot of these death excess mortality come from people who relapse, people with IRIS, and so on and so forth. So even treating these patients at the beginning effectively make a huge difference in mortality in 6 months. The only difference between these two groups are the really intervention. All these patients are exactly the same. And this is the quantitative culture assay that I showed you earlier that we did in the lab. Very simple, but it really makes a significant difference here. As you can see, M4B group, the fungal clearance is significantly different, 4 times faster compared to the itraconazole group. And this explained the mortality difference that we saw. But also, in our analysis of predictors of mortality, enrollment fungal count is the single most important or powerful predictors of short-term 2 weeks and also 24 weeks mortality. So do this quantitative culture at the beginning when the patient come in and follow them actually is the single most important biomarker of mortality. And without that, we wouldn't even know, basically the next trial you would have to power for mortality difference. It took me 7 years to conduct this trial, and it's a long time to come up to an answer. And if we can use this fungal clearance as a surrogate endpoint or a secondary endpoint, we can use that as an outcome for a trial. We can really speed up the evaluation of novel diagnostics. So that's what we're doing with Duke Biostatistics. We want to look at this fungal clearance dynamics and identify exact point at which it will predict outcome for patients, and it will power our studies based on that, so that it's a much more efficient clinical trial. So I'm going to end with a slide on wisdom of satisfaction and success for beginner student like you. And these are basically from my own experience. I think first is to know thyself, know what you like to do, follow your passion, and know your strength and your weakness in your research. Number 2 is invest intellectually, really, in order for you to give to the community, to make a difference. You need to have something to give, and that I think you need the tool, you need the knowledge of epidemiology, statistics, or whether it's be lab work, but we need to invest in education and skill, and follow mentor, identify mentors who can teach you, but do the hard draft and invest in time before you can make a difference. Another thing is take risks and don't be afraid of the road, let's travel. I think what I did was to say no to all the job offer after fellowship and took the role less travel and take some risk. For you to do global health research, you need to put yourself out there to live in a different country and learn the different cultures and hardship and all that. You need to learn how to take risks and don't be afraid of doing something that is not conventional. Obviously not to take tremendous risks and put yourself at risk, but I think the payback is tremendous when you take risks. And then think big picture. How is your work going to make a difference? To not just to the patient, not to the individual patient, but also to the big pictures, to the disease. But try to identify your niche as well, and that's really, really difficult. What I did when I was in Vietnam was I basically abandoned my work in HIV drug resistance. Not abandoned, I still do some work in it, but I really saw an opportunity to make a difference in this disease, and that would be a niche. And don't be afraid, don't think that it's a small problem. Small problem is all right, but if there's not a lot of people working on it, that's your opportunity, and you can make a big difference. So identify your niche, but always think how you're going to make a difference for patients. And in anything you do, you have to work with people, particularly in global health. You're going to be working with people, and the more effective you are, the better. And to be effective, to be influential, you need to be endearing, to be well-liked. People need to like you, to work with you, and that's really important. And be inspiring for other people. But to be inspiring, you need to first be inspired. So watch and talk, ask questions to your mentor who have been there, done that, and talk about their experience. And last is to follow through. And this is very hard. You can be inspired, you can enjoy, you can think about all these things, but you need to deliver and follow through. It's very hard, believe me, but we need to deliver the result. I've read many CVs, I've been in many panels to select medical student, resident, and fellow, and I read many CVs, and they've done many different things, volunteers and different things, but you want to look at the output. And when you see a paper, anything written, grant, where you are a big player, always carry a lot more weight. So think about the impact, think about you have to deliver and work and deliver it. And that's basically it. I wanted to thank my team. This is all the investigators in the trial, but a lot of these people is working on multiple aspects in our funder, and I will leave you with the photos of Vietnam, in Vietnam, and encourage you to come and work with me and work with investigators who work in Southeast Asia. Thank you for your attention.